I'm Theodore Cicero from the Department of Psychiatry, Washington University School of Medicine. I've been here for 50 years now and have had most of that career spent doing drug abuse research. More recently, we've shifted from animal models of drug abuse into actually looking at epidemiology and the background causes of the prescription opioid abuse crisis that broke in the mid 1990s. Today, I'd like to sort of go through a lot of the data that we've gathered over that period of time and to also sort of give a face to this crisis by interviewing people directly and asking them to give their candid responses to our questions and answer in their own words how they feel about the drug crisis that they're currently in. All right, the prescription opiate epidemic, let's look at the last 20 years and what events have occurred. And again, a lot of these opioids are either the hydrocodones or the oxycodone products, which are quite prevalent. They're prescribed the most frequently, and those we see a great deal of on the street as well. There were really two events in the 1990s, early 2000s that initiated this whole crisis. Probably the most important was the Joint Commission on Accreditation of Healthcare Organizations, which suggested or indicated quite clearly that pain was vastly undertreated in this country, even though we had excellent analgesics to relieve that pain, namely the opioid analgesics. They commented that physicians weren't using opioids in the appropriate way because they had an irrational fear of opiate addiction, which turns out not to have been an erroneous conclusion. But the fact is, at the time, the available data did suggest that pain was being undertreated and opioids could be used more frequently. This had a very large effect as we looked at the onset of prescriptions during this period of time, and physicians really got on the bandwagon at this point and prescribed lots and lots of opiate drugs. The other development was the release of extended release oxycodone. The principle there was that if you only had to take one pill every 12 or 24 hours, that would be especially useful for elderly people or those who had some difficulty keeping track of the medications, the immediate release medications, which are 4 to 6 hours to medicate. Oxycodone became enormously popular, not only because it was an extended release analgesic, but it had a huge reservoir of native oxycodone. Most pills today that are used are acetaminophen, but that addicts don't like particularly because they don't like to inject it or snort it. The oxycodone that came in the extended release version did not contain acetaminophen. It was a perfect cocktail, a perfect recipe for the use of oxycodone. These drugs were a novel idea. They hit the market, and they took off in a remarkably fast fashion, as you'll see in the next slide. The number of prescriptions written for opiate analgesics, both because of the pressure to treat pain and also with the Oxycontin coming along, which was quite beneficial. You can see over this 5 or 6 year period, there was a stark, steady increase in the use of prescription opioids. Unfortunately, as you have more opiates prescribed, there's almost a corollary increase in the number of deaths from overdose and admissions into treatment centers for opiate addiction. And you can see the sales in the middle line there, indicating that as sales went up, these drugs became more popular to be used and resulted in a lot more deaths per 100,000 people. And this was an astounding increase in the use of opiate analgesics. And in fact, though, the problem is there's a good correlation, as you can see from this figure, in the sales and use of opiate therapeutics and the adverse events that occur with its use. So much of what we saw then, this beginning surge in the use of prescriptions by physicians, which was potentially useful but probably overdone, as the more and more of the drug got on the street, and particularly oxycodone got on the street, there was some diversion for non-therapeutic purposes, which is what you're seeing in this slide. Okay, why are prescription opioids so popular? First of all, they're euphorogenic. They do produce a high, or as we'll get to it in a minute, really not a high. They're legal, they're approved by the FDA, and they're prescribed by doctors. They're seen as safer than other drugs. They're trustworthy and predictable. And by that, I mean, as you can see from the next couple of points, one has a pill, you can identify the pill immediately by its markings, by its numbers, and you can see that this pill is a 5 milligram dose of oxycodone and acetaminophen, for example. that is a high degree of certainty that that pill, in fact, has that dose of drug, and it's carefully mandated by the FDA. So a patient can be quite comfortable in taking 1, 2, or 3 of these tablets, knowing what his total dose has been over that period of time. This was viewed as a perfectly safe way of getting whatever effect you got from the opioid, and you didn't have the stigma of a junkie. And addicts at the time in the early 2000s considered people that used heroin on street corners and IV injected drugs, they were junkies. But taking a pill from a doctor at a prescribed level was more civilized in many's eyes, and it simply wasn't, I'm only taking pills. They're legal pills at that. I'm not taking heroin, so I'm not really a junkie. You can see from this chart and this figure, in terms of least risky drugs to the most risky drugs, you can see heroin at the bottom, and looking over at 3 different periods there, different stages of development. But in all cases, use of opiates like Vicodin, Percocet, and Oxycontin were less risky than heroin, of course, as one would expect. But over time, there was a movement in the direction of more risk at that point. That should give you an example of the most commonly drugs you're likely to use. And this is a couple of quotes. Again, I want to give a face to these people. These are real people who are telling me their life stories. And they say, with regard to prescription drugs, a doctor prescribes them to you, they can't be that bad. When you're on the street, the person that's doing heroin is a junkie. If you look at a person that's doing Percocets, they would say, well, I just do Percocets. You know what I mean? For a long time when I did Percocets and didn't do dope, I looked at people as if they were junkies, but I wasn't. And that's a prevailing sort of view as you go through this. Where were they getting these drugs from? You can see in this figure, about 39% of our population of people who were entering a treatment clinic and were given an anonymous survey, about 39% indicated that they used doctors. Doctor shopping could either be they went to multiple doctors to get multiple prescriptions, or they got one prescription and managed to get it copied in some fashion and filled it at very different pharmacies, which if they don't communicate with one another, there's absolutely no way to know that this patient may be doctor shopping. The other is, unfortunately, a contribution to this 39.4% is the fact that many physicians are ill-informed about how to prescribe opiate drugs, are insensitive to the signs that someone may be opiate problematic in terms of using opiate abuse, and they fall in this category too. But doctors do, in fact, account for about at least 40% of the total diverted drugs are due to doctors prescribing. Some of them unethical, some of them less than reputable in many ways, but a lot of this is just physicians who are simply not knowledgeable about the source of drugs and how to use them, use guidelines more effectively. About 35% of the people used theft or forgery. This generally involved themselves stealing something or using actually a dealer at this point. And you can see actually the rest of the categories are fairly low over this period of time. The really primary source, almost 80%, is in fact coming from a doctor's prescription or as a theft or forgery of a prescription. Important point is there is an age relevancy here. If you look to the left, which is dealer, and look to the middle of medical and then shared and stole, we asked people in various age groups, 18 through 24, 25 to 34, 35 to 44, and 45 plus, to indicate to us where they got their opiate. You can see the younger people especially use a dealer over 70% of the time, but as they got older, that number drops steadily. One can speculate that that's due to risk aversion that grows with age, but that the younger people are not so sensitive to potential damage to their cells and will use a dealer much more often. If you look at the medical source, though, it starts out at quite a low level. Healthy people don't use doctors that often, so it's not as easy to get medications from them. But as they get older, the use of the doctor has increased markedly. So the take home here is that a dealer may be the prominent source in a younger, healthy person, but as individuals age and it's also sex dependent, as females age in particular, they use more and more drugs that are actually coming from a doctor in some fashion. The pill brokers were in our neighborhood one night asking for people with the red, white, and blue card, which is the Medicare Medicaid program. And if you had one, they sign you up right there. I think they pay $50 for signing up right there on the spot. They also pay $80 for the doctor's visit and $200 for the pills. That sounds like an awful lot, but when you really break it down, it's not. An Oxycodone tablet on the street usually sells for $1 per milligram. So a typical drug one gets is 80 milligrams, which is about $80 per pill. If you get a prescription for 30, you can do the math. That's a very large income that could be, or very large rate of income on your return, if you will. So giving out $300 or $400 to patients, especially Medicaid patients, and then having them get the pills for you, and they make a nice profit themselves, and of course the dealer makes out a very nice profit at the expense of the people using it. In terms of their total state of health, I think you have to understand these patients that you're seeing that come in with pain have a number of disorders. This is just an overall, and it shows you the relevance of gender here, but it shows the scores on what is called the SF-36, which is a general health category, which scores people in terms of their overall physical and mental health. And you can see the population norms are around 50. That's just standardized the way that the test is constructed. And women's tend to be a little, and the lower the number, the more ill they actually are. You can see women tend to, generally speaking, have a minor, but nonetheless, it is a significant difference in the amount of discomfort they feel in a number of areas. But if you look at the various scales, and I won't go through all of them, but if you look at the various scales, you can see all of the people who, again, we're surveying, those that are addicted to heroin or prescription drugs, do much worse health-wise than other healthy individuals. Women typically do much worse than men over this period of time. And if you look at the psychiatric indices out on the right-hand portion of this slide, factors 6, 7, and 8, it's quite clear that there is a significant amount of comorbid psychiatric disorders in these individuals, particularly, once again, in women. So I think, again, the point to emphasize here that this is a problem in men and women, and particularly as they get a bit older. There are psychiatric and other kinds of issues, and you'll see some reasoning for that in just a minute. If you look at the overall differences between male and female, and look at various indices in the left-hand column, you can see chronic pain is a common feature in all of these individuals. Over 60%, females a little more than, or sorry, a little less than males in this case, but they actually are self-reporting pain is of a chronic nature. If you look at the self-reported pain score, you can see many people are scoring between 5 and 6, which is a moderate degree of pain. And this is a steady state condition. They feel this way for a long period of time. It's not something just acute that day. This is sort of a chronic level of pain. So I think, again, overlaying this is these people do have other kinds of issues, but they also have a significant amount of pain that's by and large treated, but not treated as well as perhaps it should be. The reason for first use of an opiate for pain is really interesting. And if you look at the totals there, 81% of the people, total, a little more females than males, showed that they actually used their first medication was in fact what you hear that it was to treat acute pain. So the old axiom that you hear from very wealthy individuals, in particular those people overdosing in the entertainment business, is it's not my fault, I got hooked by a doctor. There's some truth to that in the fact that many of them did start with an opiate that was given for pain, but then evolved into abuse. By no means should you take from this that all people that we're interviewing or that exist out in the population, anyone who takes an opiate drug is at danger. That simply is not the case. In this connection, there really was a novel experiment carried out in Lexington, Kentucky, about 75 years ago, in which they gave an injection of morphine, 10 milligrams of total injection, into male and female prisoners, which you would have a hard time doing that study today, but they gave them to prisoners and people who worked in the prison system to see what effect they had. Interestingly, 90% of the people found the experience very unpleasant. That first exposure to morphine was extremely unpleasant. About 10%, though, thought it was the best feeling they ever had. These data point really quite heavily to the fact that these individuals, there are some individuals who are highly vulnerable to using opiates on the first time they take it. What is it about these people that distinguishes them from what we would call normal individuals is really unknown at this point, other than there are some other indices, which hopefully we'll cover a little bit today. But this is not a uniform response, certainly. Not all people taking opiates are going to develop a problem with opiates. Many find them unpleasant, and they only take 2 or 3 of it, 30 milligram or 30 pill prescription or less. So people use less of the drug, so they really don't like the feeling, except for this subset of people. There's a self-identified psychopathology. About 60%, about almost 2/3, have psychiatric disorders. You can see them listed there. Depression and anxiety, by far, especially depression, are the most common illnesses seen in these individuals. So if you've got a person coming in who's got some pain, but who has a lot of psychiatric history, I think in those particular individuals, not that you shouldn't give the drug to them, but you ought to be very careful in monitoring their behavior over time. If you look at ask again, patients coming to you, previous substance abuse, these people are certainly not psychotomimetic naive. They have experience taking other drugs to alter their mood or alter their behavior in some fashion. 89.6% have actually used some substance. It could be alcohol, it could be nicotine, marijuana, prior to using their first heroin injection. So obviously some history of drug abuse is common in this population. About 5% took them at the same time rather than preceding it. So you've got 95% of the people who have prior drug experience before they're exposed to opiates. This next figure gives you an idea of the types of drugs involved. You can see in the population, alcohol, nicotine, marijuana were very popular drugs. About 90% of the population in general had used those drugs prior to their first exposure to opioids. So they had experience with drugs that modified mood and were quite accustomed to that particular feeling. You can see on the right-hand panel, any stimulant use was about 80%. And they find a lot of people in these populations who have used drugs for ADHD. Again, it's a stimulant, but it does produce mood alterations and a feeling that most people like quite well. Benzos are very high. About 60% individuals have used benzodiazepines before, and about 55%, not an insignificant number, have used a hallucinogen. So as you do drug screenings, I think it's quite important to ask in the history of it whether they've taken these drugs, how much and when, and how did this precede your drug use. Because it's possible some of these effects could be due to the use of opiates, but more than likely it's due to the fact that they've had some experience with getting high and want to maintain that high. They're actually experimenting further, trying to get high with something else. Okay, the initial opiate exposure, we go from anticipated benefits to opiate misuse. But here's the initial effect that people have. Minutes after doing them my first time, I felt there was not a care in the world to me. Nothing and no one existed except for me and the amazing high I was feeling. But the most succinct quote, and probably the one I like the best, is, "It was like God was petting me." Now, it's difficult to imagine what that would feel like, but as we asked this individual to expand a bit further on what he was saying, I was in the arms of God. He was running his fingers through my hair. I was comfortable. I could hear his heartbeat. I brought him closer. He brought me closer and closer to him, and I felt so comfortable that nothing in the world was going to bother me. No one was going to be able to get to me. I wouldn't be depressed. I wouldn't be anxious anymore. So God was in some way protecting them. Now, that's an enormously potent effect. If you actually really do feel like you're completely safe and secure and under no pressure when you're on opiates, that's a powerful motivation to continue. This gives us a little bit more information on opiate abusers who actually looking at psychiatric disorders. About 75% self-reported that they had used opiates to medicate for psychiatric-related issues, generally depression. About 85% reported that they tried to escape from life, and the high to them this was very important. We asked them, what does high mean to you? And very rarely did it conform to the usual picture we have. Getting high, you're often in some euphoric state, you're seeing things, or whatever, these people are reporting a whole different set of responses. They feel better about themselves. They feel comfortable. They are escaping from unpleasant life circumstances. Either they're going through divorce, they've been depressed for a long period of time, and particularly self-esteem in most of these individuals is quite low. Gives you some idea of people's initial response. Finally, relief, not only for the pain of the broken collarbone, but most importantly of my mind. I love the feeling of euphoria. I felt comfortable in my own skin. I could talk to anyone. I felt what I thought I was supposed to feel like. Extremely happy. I knew I had found the secret to my happiness. Well, I was wrong. It ruined my life. The escape was from the real pain I had from the back problems, but also it allowed your mind to release and think in comfort rather than in a stressful way. I have never been as successful or motivated or feel as good as when I was on opioids. The last quote here is, they made me feel I could talk to people and not be scared or embarrassed to walk around and just talk and be part of society. A very common thing. These three quotes are representative of our entire population. Again, stress the fact that the effect of the opiates is not really getting high in this case after the first couple of times. It's actually treating themselves, making themselves feel more comfortable. The best example of the person that made the comment in the very end is that, last on this slide, is that he was a very shy individual, good-looking young man, athletic, had good grades in school, the last person you'd ever expect to see taking opioids. But he was so shy, he couldn't approach people. He didn't think people liked him very much. He was very nervous, and he had very low self-esteem. When he took opiates, all that disappeared, and he became outgoing. He became the life of the party. He could pick up girls. He felt like he was really comfortable, and really summarized to just say, I really am a better person when I'm on opioids. Again, a very difficult argument to make. And when I stressed to him, this is you that people like. You're bearing it under a whole bunch of inhibitions, but it's you that people like. You don't become a different person when you're on drugs, but you're actually relieving a barrier that you have to express your inner self. He said, I understand that. I understand that. After we talked for quite a period of time trying to talk about his self-esteem issues and why he was so self-conscious, he got up to leave and basically indicated, I know what you said. You've been very helpful to me, but I will continue to take opiates because I really honestly do believe I'm a better person. It's a very powerful statement, and you can see as you treat these illnesses and deal with it, you've got to worry about this underlying issue. It's far more important than just, again, getting high does not describe this. These are people who are have some deep-seated insecurities and a very low self-esteem that need to be treated. What should be obvious from the slides we've discussed to this point is that we do have an epidemic, and I doubt that anything more I could present to you would convince you that we really do have an epidemic. Again, 60,000 people a year are dying from this use of these medication, which is the high point in history, as best I can tell, for opiate-like deaths occurring. But to confront the epidemic, there was a lot of aggressive moves made to really, on a supply side effort, easy prescription monitoring programs. There's a crackdown on pill mills, a lot of physician education, and a lot of abuse deterrent formulations. The abuse deterrent formulation is interesting because addicts don't typically take their drugs orally. When they first start, they try to take drugs orally, but after a period of time, they usually crush the pill in some fashion so they can snort it, or they dissolve it in some sort of solution and inject it. That is the area of most interest to addicts, is actually to inject this or snort it because you get a much more immediate effect. Abuse deterrent formulations resist crushing and resist solubilization. They can't eliminate people who solubilize their medications because, by definition, if you take an opiate orally, it's got to be dissolvable at some point in stomach fluids and get into the system. So that abuse deterrent aspect has not, for those taking drugs orally, has really simply not taken place at this time. But there are some very effective drugs that could in fact be used that would deter people from crushing it or snorting it. Have they worked? The answer is yes and no. If you look at oxycodone and hydrocodone, the dark blue line and the red line, you can see that these have decreased over time. When around 2010 to 2012 is when a lot of abuse deterrent formulations came on the market, and you can see a steady drop off over that period of time in prescription opioids. The rest of the opiates are at the bottom, but they're used so infrequently that it's hard to see any trends, and there really aren't any significant trends one way or the other. Oxycodone, hydrocodone, used by about 90% of the population. They have decreased markedly so. But the devastating part of this and the development was what happened in consequence of the supply in prescription opioids. Heroin use has risen steadily over that period of time. It's actually increased by about 50% over the last 4 or 5 years, and that line is growing and growing. This is an unanticipated effect for sure, but it was logically to happen because if you limit the supply of prescription opioids, these people are simply not going to stop taking opioids. They're going to move to something else, another opioid, heroin in this particular case. We did not anticipate this, and the country simply wasn't ready for an unanticipated consequence. You can see why heroin became easier to use at that point. It became easier to find heroin than good oxys. Also, heroin was cheaper because of the change in the Oxycodone formulation. That is, when it went from a non-ADH form to an abuse deterrent formulation of Oxycodone, it did get much more difficult. So people said they tried heroin for the first time. I did that in part because you couldn't smoke or snort the Oxycodone pills anymore, so I resorted to something you could do that with. I heard the heroin would get me higher and was cheaper. And when the oxys changed, so did my choice of drug. Issues with heroin, as stated here, they're cheaper, they're easier to get, they're easier to inject, and they're purer than ever. You can see what they're injecting is not a sterile solution by any means. And the fact is they just crushed it down to particulate matter. And if you can see inside the syringe there, this is not a pure, clear liquid as you would expect to get. You're actually injecting small chunks of heroin as you go along. Obviously, a very dangerous route of administration for a whole bunch of medical reasons. Sharing needles, of course, has its predictable effects. So this development is indeed a very frightening one. Why does heroin use grow so rapidly? Again, heroin is cheaper and stronger than prescription drugs, and the supply is typically pretty consistent. But there is significant evidence accumulating that the stigma associated with using heroin, as you recall from earlier in my presentation, people that were initially taking prescription opioids because it wasn't heroin, and they weren't a junkie. They were, in fact, prescription pill users. Now, all of a sudden, in order to overcome the barrier of the reduction in the supply of opiates, there had to be a change in the stigma associated with using them. You can see the evidence here in this quote from a woman in her 40s. Dealers and people around them are middle-class white kids. Not even kids. We were all in the age range of 25 to 41. It just became easy, and we weren't really looked at as being addicts because everyone thinks heroin addicts are all homeless, shady-looking, dirty junkies. And to that point, if you look at the changing demographics from 1960 through 2010, the decade they first started regular use of opiates, you can see back in the 60s, this was primarily a male-centered epidemic at that point, with females contributing relatively little to this population. But over time, you've seen a convergence of the two lines. And right now, at this stage, we're looking at both men and women about equally are using heroin, a marked reversal for what it was in the 1960s. So if you look to the right, you can see the non-white versus white. And again, emphasizing the point that in the 60s, this was, in fact, pretty much a non-white issue driven by, again, mostly inner city people. But you can see the number of non-white people has decreased sharply over time. So this is a complete reversal of patterns. Previous users being young minority males living in an urban center. The new user is an older white male and female living in a suburban or rural area. The perhaps most frightening development that we've picked up in this paper's in press and should be published shortly is the first opiate abuse. Now, if you look back at the stages like from 1998 through about 2010 or 11, the first opiate abuse was rarely heroin. People just didn't jump into heroin. They took pills first, and then they graduated to heroin. What we're discovering is a lot of people indicate that for the first time, that they used an opiate, it was heroin because it was available freely at the parties they went to or whatever. And you can see that number is rising really dramatically at this point. And the last couple of years' data, which are not plotted here, are showing the same increase over time. That is frightening because you've got people who have no tolerance development at all. Now it's starting out with a very powerful drug that'll test their limits of tolerance. And what do you see in that case is predictable. You would see a rise in heroin overdose deaths. And you can see the association there. I've just juxtaposed data from the CDC against our own data. And you can see that as heroin being used as the first drug has increased, there's been a substantial increase in the number of overdose deaths, which is highly predictable because, again, you don't know when you get some powder form of heroin how pure it is or if it contains other drugs. And the big concern now is fentanyl is the least expensive drug of abuse to be on the market. It's very easy to use. It's easy to make. It can be imported mainly from China, but then it goes surprisingly to Canada or Mexico where it's processed in some fashion and then ends up eventually as a component of heroin. Worse than that, when you introduce a fentanyl into the heroin solution, you have multiplied its toxicity by several fold. And it's really becoming very difficult to estimate dose because you don't know what purity heroin you have and you don't know whether there's been fentanyl. So it's very easy to overdose and to die. The last and the most important point I think to raise here is we are addressing this problem in the wrong way in this country. We're focusing solely on the supply of drugs, and clearly that hasn't worked. We may have decreased the abuse of some opiate medications, but we haven't touched the bigger opiate problem. We've just made people change preferences. What do? We have to start addressing the demand. We need to know who these people are, and that's what I tried to give you a little sample of today, and how can we best treat them or prevent addiction in these individuals. And again, you can't emphasize enough psychiatric issues. Until we address this demand, it'll be met. There's more powerful fentanyl analogs coming down the pipeline, and there's a lot of chemists busily working to make more addictive substances. Here's my information, and I thank Andrew Yee for the excellent preparation of the thing. And here are a bunch of references that we've published over the last couple of years that you might all find helpful.